So we'll open this to discussion, and I also see Dr. Saroj Das, who has joined us.
Good morning.
Good morning. How are you?
I'm fine. I'm fine, as you can see.
We have Dr. Venkatesh here and Dr. Rodney White and Dr. Manutosh Panja. We'll just be briefly discussing about the three talks on ascending aortic endografting for ascending aortic aneurysms and treating acute dissections with stents and covered stents. Also on polymer-coated based technologies and endografts for infrarenal aneurysms and management of pulmonary AV fistulas. So, yeah, Dr. White is there. So I would, since I'll ask Dr. White to sort of lead the discussion and ask be the panelist about their comments.
And Dr. Panja here, my question to Professor White, what is the role, how much role of the multi-layer flow-directed device in the arch of the aorta?
Well, that's yet to be determined. In the US, we don't have a trial to look at that or availability to the device. I think Evo's had the most experience with that, and Vinky also has been exposed to this technology for a long time. So those two are better to be able to discuss and answer that question.
I think, Rod, we were involved with Dr. Dietrich, with the multi-layered stent. We did 50 pigs, and we did a lot of the initial studies. Unfortunately, I think we could not get a study going in the United States. So I think our experience with the multi-layered stent, especially in the United States, is pretty limited. I think a lot of this work is being done OUS. And so it would be really nice to have a study in the United States and bring this device to fruition into the market. And I think that's one of the limitations of the multi-layered stent.
Yeah, Henry, I think that Henry is working in this subject of multi-layer for more than 10 years. He has got enough experience in Europe. Next question is how maintain the coronary height in the ascending aorta. You are giving the stent graft from the ascending aorta, particularly how take care of the origin of the coronary artery.
Vinky, there was a case that Ted had where they actually covered a coronary, and I saw a 5-year follow-up on that where it was still patent. So Evo's, maybe he's muted and with us or not, but has done that. So, but hopefully the company's been reorganized, and hopefully there is going to be a study in the United States that will happen here.
And also, I think the features of the multi-layered technology would probably be more applicable to dissections. What do you think, Rod?
Yes. Yeah, that's right. And that's where it took a bad hit in Europe, because data that supported it in the aneurysms is not, well, because of the core lab issues and some other stuff, it's just not a good device for at least large aneurysms. And but for dissections, it's a totally different perspective, and the data there is really very promising. So,
and in terms of even the arch, I know, Rod, you've got a lot of experience with the arch. There are a lot of companies and devices that are coming up. Like we've got the endospan device, you've got the single branch devices coming in, and then Dr. White has his own IDE regarding branched vessels for the arch. And I think I'm a little surprised that we don't have technology for the arch, as these vessels can be easily accessed, from outside or from previous neck incisions or even arm incisions. So the arch is going to be technically challenging, but I think it will eventually come about to have a branched or a arch graft, whether it be for dissections. There was data on about a Bentall procedure that was done totally endovascularly also. So arch is becoming our target right now. We sort of still have issues with dissections.
Oui, là je vais commencer. Comment je fais pour...
Yes, Dr. Venkatesh, there is another important question in cases of Marfan-Hyde syndrome, with the ascending aorta highly dilated, aneurysm formation. And here the intervention role, Dr. White is mentioned, that is very applicable. So what is controversy, the surgeon versus intervention cardiology in case of the morphine ascending aorta?
Moi, je me vois, oui. Je vais commencer, moi, dans 5 minutes.
Getting a lot of feedback, but I still feel in patients with Marfan, the surgical approach might still be the most appropriate right now. And eventually technology may come about, but at least at the current time, and Dr. White can elaborate on this, at least at the current time, I think Marfan is still a surgical operation, except for those patients who are really, really high risk or in emergency cases. What do you think, Rod?
Yeah, the aorta is going to continue to degenerate with those patients. So for that reason, surgical is still the standby. There have been reports of Marfan's patients being treated with endografts, and it's a controversial conversation to enter into. The other thing is, a lot of patients are told they have Marfan's, but they haven't been tested, and there are so many syndromes yet to be identified that there's a lot of work to figure out who's exactly Marfan's, who's got some other syndrome, and how are we going to do that. The other thing to follow up on Vicky's comment about the arch is that is going to happen. One of the challenges is stroke, but we're going to learn how to treat that also. And the reversal of flow technologies are going to develop there, I think, too, to help us out. So this is all going to happen, and it's coming very rapidly. But you're right, access from the neck is easy, and you can put these devices in. So we're going to get there, and 5 years from now, I think that's going to be a standard technology. Just working our way through it.
Rodney and Benke and Ivo, can I ask all of you that the principles of carditis, or the multilayer flow modulator is so attractive, yet there has been very little progress during the last 10-15 years about the use, particularly for the Marfan's very complex aneurysms. Can you discuss some idea why it hasn't happened?
Well, yeah, it's a complex issue. The company itself, which has been reorganized recently, was challenged, I think, by some of the other graft companies in Europe. It also never really got a study put together in the United States, which, even though the European data is very helpful, it usually takes an FDA approval before, it takes off. So I think but there is a reorganization now that's taken place and going to be a better organized study. So the answer to the question you just ask is going to, I think, be resolved in the next 4 or 5 years in a U.S. trial. And but it is a very appealing technology. And if you look at some of the long-term dissection cases, it's extremely impressive. I don't know how it works, but it does work in the majority of those patients, and it's a very useful device if you use it appropriately.
I agree. It's going to take some time. But again, the trials have to be done, the data has to be presented. And I think if you focus on dissections and the company can initiate a trial, I think this is very fascinating technology, and I hope it comes through.
Yeah.
So, as always, it's a zone 0, which is the most problematic area and probably the last unconquered area in endovascular treatment of aortic aneurysms and dissections. And the other way to go about is the polymer-based technology. But let me ask you a question. When Dr. Ted Dietrich was here, he was very excited about epigenetics and manipulating the genes to actually control the progression of aneurysm. So where are we right now in terms of genetic manipulation and epigenetics and genetic treatment for aortic aneurysms?
Well, I think that's going to come too. Yeah, it's and Jacques is on there. I know he's got a study they're interested in starting in the U.S. Jacques, you may want to weigh in and take your mute off, but you may still be on the phone. Go ahead, Vinky. You were going to say something.
Yeah, I think in fact, there are a couple of studies that are still ongoing, and it's going to take a while. But also, not only Dr. Khanna has mentioned, epigenetics and genetics, but also drugs. I'm involved in a trial that we're doing right now, where we inject this drug called PGG into the aneurysm sac itself. And we've done 8 patients, 4 in Hong Kong and 4 in Colombia. This drug is supposed to cause cross-linking of elastin and collagen and strengthen the wall of the aorta. And even in those 8 patients, we've seen significant stabilization of the aneurysm. So I think there's a lot of work going, not only in terms of preventing or stabilizing the growth, but also in advanced technologies such as the arch. Another thing that I would also like to bring about in this aortic section is the follow-up of patients. The FDA mandates that all of these patients who undergo TVARs and EVARs and about 35 other devices, that they have to be followed for the rest of their life or the life of the device. And if you look across the board in all of the most sophisticated academic situations and institutions, the average follow-up of these patients with EVAR and TVARs is about 50% or 53%. And that has to be made better. We need to have better follow-up technology for these patients so that our compliance rate to follow up these patients for 5 years, 10 years becomes markedly better. And if the current technology of apps, if a company like Ford can recall 10 million cars that were done 5, 6, 7 years ago, and they had tracking of all of these cars, we should be able to follow these patients that we put implants in. And that's why we started a company called Metrac, which will allow us to follow these patients much more closely from 50%. Even if you increase the compliance rate to about 80, 90%, I think we'll be in a better position to treat these patients and avoid, graft failures, migrations, ruptures, and treat them much more effectively. So I think these are all the issues that we have with aortic stent grafting, aortic technology, right from the multi-layered stents to epigenetics, genetics, drug pathology, all of these, and follow-up of these patients. So it's a very challenging time. And I think all of these technologies are now currently becoming available. And I think in the next 3 to 5 years, as Dr. White said, we will be in a much better situation to implement all of these technologies. I see Dr. Reed. Donald, any comments? Unmute yourself.
You're muted, Donald.
Unmute.
There you go. Yeah.
I really am most interested in your idea to inject a medicine into the sac of an aneurysm, but I'm an old-fashioned, simple surgeon. I find it difficult to think that could succeed, but it's remarkable to try it and strengthen the wall.
Well, we're doing it for smaller aneurysms from 3.5 to 5, just to see how. Obviously, the data is not out. It's going to take a long time.
Better be careful not to puncture it.
No, we don't puncture it. The way we do it is we put in an infrarenal occlusive balloon, and then there's this huge perfusion balloon. And with infrarenal occlusion for about 2 minutes, the entire drug is perfused into the aneurysm sac. And then you're done. And then you close the groin. So it's not like puncturing the sac.
Well, the other thing, Vinky, that confuses this surveillance issue is we, always chose the high-risk patients first for endografts. Yes. And they get sick. The other thing is, historically, we put an aortic graft surgically in a patient and then tell them you're going to be okay. And we never surveilled those devices. If a standard aortic graft now went to the FDA in a panel meeting, they would have surveillance requirements just based on what we know are, what we call routine failures, anastomotic stuff, dilatation later, so the surgical standard for what we've done in the past never really looked at surveillance and natural history and those folks the way we're doing it with endografts. So we're learning it now, but from the endograft side, and eventually, again, I think we will do that with conventional vascular grafts and find out,
yes,
a lot more stuff. So it's what happens with rapidly evolving technologies, and it's fun to be part of all of it. It changes every day. So
At the recently concluded WEATH meeting, which was really impressive too in the COVID situation, there was a lot of discussion about artificial intelligence too. So with a combination of all of these electronic follow-ups, apps that are coming into the market, virtual presence that you can actually see, and artificial intelligence, I think this concept and the follow-up of aortic aneurysms, whether they be miles away. If a patient goes from the US to India or to Europe, how do we surveil those patients? How do we track those patients? So I think surveillance is something, even at a recent FDA panel with Endologics, because of the AFX2 device, there was a huge discussion between all of these stent graft companies regarding surveillance and follow-up of the patients. And I think the FDA is paying a lot of attention towards that aspect of aortic endograftment.
Thank you very much, all of you. And yesterday we had a good session on AI, and one of the talks was on, predicting endoleaks right from the time you do a diagnostic CT before you plan your device for endoleaks, and also surveillance with a chip in and measuring the pressures from a remote sensing. So those are the things to go. We have a big session. We have 2 sessions on aortic interventions today. Thank you all very much, and we'll move to the next session.